In this video, we will use a simulator to review the basic equipment and procedures for endotracheal intubation. First, it is essential that you have a bag valve mask as well as a suction catheter. Bagging is an essential skill both during induction as well as for patients with difficult airways who may require multiple intubation attempts and reoxygenation between attempts. The bag should be hooked up to wall oxygen at the highest flow rates possible. Next, you should have a direct laryngoscope. Here we have demonstrated both a Macintosh and a Miller blade. Prior to intubation, it is essential that you check your light source on whichever blade or blades you intend to use. The Mac blade will be advanced into the vallecula just proximal to the epiglottis, enabling epiglottis visualization during the procedure. Conversely, the Miller blade should be advanced past the epiglottis. You should have two tubes available, both your intended endotracheal tube and a tube that is one size smaller. Insert the stylet and check the cuff inflation prior to use. Some physicians will also choose to apply lubrication jelly at the end of the endotracheal tube to ease passage between the vocal cords. A backup device should also be present and is essential in any anticipated difficult airway. The laryngeal mask airway is a common backup device. As with the endotracheal tube, the LMA cuff inflation should be checked prior to use. Unlike the endotracheal tube, which may require only 5 to 10 mL of air, the LMA requires a full 30 mL of air to inflate the cuff. The bougie is a firm, pliable plastic rod with an angulated end that allows for passage into a narrow or partially obstructed airway. The endotracheal tube can then be fed over the bougie and into the trachea. The end-tidal carbon dioxide monitor, or end-tidal CO2, allows for detection of appropriate endotracheal tube placement. When carbon dioxide is detected, the end-tidal CO2 monitor will change from purple to yellow, indicating correct placement. Only after setting up your equipment should you then proceed to induction and intubation. During the induction, the physician should begin masking the patient by applying upward pressure to the inferior aspect of the mandible to open the airway, rather than downward pressure on the mask, which will compress airway tissues. The mouth should be opened using a scissoring technique. This allows for maximum opening and visualization of the structures. The laryngoscope blade is then inserted laterally, sweeping the tongue from the patient's right side to the left as it is advanced. Upward pressure is administered in order to achieve visualization of the vocal cords. At this point, the tube is inserted into the mouth and then advanced between the vocal cords under direct visualization. In some cases, physicians may choose to use a video laryngoscope. Here we see the video obtained from one such video laryngoscope, a CMAC, during intubation.